Good afternoon. Thank you for having me today. Today I'm going to talk about strokes. I'm going to talk about what a stroke is. I'm going to talk about how to recognize a stroke. I'm going to talk about what to do if you're having a stroke, and I'm going to talk about how to prevent a stroke. Again, kind of the main theme, my viewpoint as a family medicine physician, is I don't really want people to have strokes. And so the focus of my talk, although we're going to talk about the things I mentioned, is I really like people to walk away with two things. One, how to recognize when somebody's doing it, but also knowing how not to get one, because strokes are bad. I could probably end with that. Strokes are bad. There are two main types of strokes. There's something called an ischemic stroke. And an ischemic stroke is when the blood flow to an area of your brain is cut off. And that blood flow can be cut off really two ways. One is that you get narrowing of the artery, a plaque, kind of like you do with a heart attack, and you get a little, that narrowing gets a little tiny blood clot in it, and it blocks it off. And so there's no blood flow to that part of your brain, so that part of your brain dies. And dies with it is the functions that part of your brain did. Another type of ischemic stroke is when a blood clot forms someplace else in the body and it floats up into the artery and blocks it off. And one of the common reasons that happens is an irregular heartbeat, something called atrial fibrillation, where the top part of the heart's just vibrating and blood clots can form in there, and they float out of that and go up through the arteries and clog it off. So one type of stroke is an ischemic stroke. A lot of the time, the blockage, the main artery blockage, is down in the carotid arteries, the big arteries in your neck. And part of what they do to screen for people at risk for strokes are ultrasounds of their carotids. And people that are older and have a lot of risk factors and smoke and that kind of thing should probably get carotid artery screening. Anybody with heart disease should get carotid artery screening to look for that narrowing. But that's where a lot of it is. But there can be in other places too. A hemorrhagic stroke is a different kind of stroke. The blood flow ends up not going there because the pipe, the artery, springs a leak. And they spring a leak when you get an outpouching or an aneurysm or a bubble on the artery, and those pop. There's a genetic component to getting aneurysms. If lots of people in your family get aneurysms, you're at risk for getting an aneurysm. And actually, if more than a couple of people that are like parents or brothers or sisters, they recommend testing you for aneurysms. You've never been tested because your risk is high and you may develop those. But most aneurysms are kind of random. But those happen too. And so there's hemorrhagic strokes and there's ischemic strokes, and those are the two basic kinds. A stroke is really an acute event. It's something that happens at a moment. And an expression that we use, like heart attack, well, a stroke is kind of a brain attack. And strokes are the third leading cause of death, behind heart attacks, heart disease number 1, cancers as a whole are number 2, and strokes are number 3. Most strokes are ischemic type. Most strokes are associated with that narrowing of the arteries thing. And therefore, there's stuff we can do to prevent narrowing of the arteries. Therefore, most strokes are preventable. About half the time, I'm going to turn this around. Half the time, you're going to get a warning sign that you're going to have a stroke. Half the time, you just have a stroke. That's kind of similar with heart attacks too. Half the time heart attacks, you present with your heart attack and you keel over. Other half the time you may have some angina symptoms or chest pain symptoms prior to your heart attack. There are warning signs of stroke that I'm going to go through. And there it is. A warning sign of a stroke is something called a transient ischemic attack, or transient, short amount of time. Ischemic means decreased blood flow, and there it is. A transient ischemic attack, when a person has one, what they have is a temporary loss of nerve function where the blood flow from that artery that's temporarily clogged goes in your brain. It can be a loss of vision. It can be a temporary loss of ability to talk. It can be a temporary loss of the ability to understand speech. It can be a temporary numbness to like one side of your face and another side of your body because the way your brain's wired in. It can be a temporary loss of strength in one side of your body or in the other side of your face. But it comes, it ain't working, and then it works again. And that just means the blood flow it's sort of like an angina attack with heart disease, where the blood flow is decreased so you get the pain, but it's not cut off so the muscle doesn't die. Well, similarly, the blood flow is decreased so you lose the function, but it's not cut off so you don't have, when the function loss comes back, because the blood flow is enough to maintain it. When you get those, that's not good. You're at much higher risk of having a stroke if you've had transient ischemic attacks. And really, if you're having symptoms of a transient ischemic attack, you don't know if it's going to go away or if it's going to get worse. That's kind of a get to a hospital thing. Okay. There are various risk factors for having a stroke. And it turns out these are the same risk factors that there is for heart disease. And that's because there's a similar underlying theme, is that heart disease is representative of decreased blood flow to the heart muscle. Stroke is representative of decreased blood flow to the brain. So things that affect arterial flow to different areas are things that put you at risk for heart attack and stroke. Kidney disease and blindness too. Nevertheless, somebody who has known disease in their carotids have arterial sclerosis, they're at high risk. Somebody who has high blood pressure, just like with heart disease, high blood pressure contributes to arterial sclerosis, or narrowing of the arteries or damage to the arterial walls, so they're at high risk. Atrial fibrillation is that irregular heartbeat I mentioned before, where the top of the heart's kind of jiggly around, and blood clots form in that, and that can throw up and cause a stroke. Cigarette smoking is poison to your body. It's not good for you. It causes arterial sclerosis, and it will put you at increased risk of not only narrowing of the arteries, but also blood clotting. It kind of encourages that, which you don't really want. And it is bad for you, and it leads to strokes. Somebody with heart disease, kind of like the carotid disease, you already have known narrowing of your arteries. There you are. Diabetes is kind of, diabetes is a very obnoxious condition. It has to do with your body's inability to maintain control of your blood sugar. But what happens with that illness is when blood sugar runs around high, it's like a poison to all the small vessels, small arteries in your body. And so it causes damage to all those small blood vessels. And so it leads to heart attacks and strokes, and again, blindness and kidney problems and nerve problems. And it is a very strong risk factor for getting these other issues. And if one has diabetes, if they control their diabetes, they do a lot for preventing that increased risk from the diabetes. If you've had a transient ischemic attack, then you're at higher risk for stroke because your body's told you you're about to blow a gasket. If you don't take care of yourself, being overweight, being in poor physical condition, puts you at higher risk. Drinking too much puts you at higher risk. Having high cholesterol puts you at higher risk. And then oral contraceptives increase risk of blood clotting, and doing so they increase your risk of stroke and other blood clots. They're generally pretty safe, except with people with family history of blood clots or people who smoke. I have seen 2 young ladies under the age of 30 who've had strokes, and both of them smoked and did oral contraceptives. So don't smoke and take birth control pills. It's bad. And all those things are modifiable. They're either behavioral or there's things we can do medically to control those risks. Things you can't do anything about is how old you are. You can't do anything about you had a stroke before. You can't do anything about your genetics or your race. There you are. You got them. And factors, being older, having a previous stroke, lots of strokes in the family. Certain races are at higher risk for heart disease than others, and stroke. Okay, so the National Stroke Association has this guidelines of what you should do as individuals to help prevent having a stroke. And it's all common sense stuff to me. It's like monitor your blood pressure, make sure it's normal. If it's not normal, get it treated. If you have atrial fibrillation, you probably know it, because usually atrial fibrillation gives you symptoms like racy heartbeats and passing out and falling down and not feeling right. But you need to know about it. If you're smoking, don't smoke. It's bad for you. If you drink alcohol, do so in moderation. Now, what's moderation? It depends where you live. If you're in England, it's 5 pints a day. Go England. But in the United States, 2 drinks a day for a guy, 1 drink for a lady. And that's considered moderation. So we're all going to move to England and hang around in pubs. Get your cholesterol checked. If it's high, get it treated. If you have diabetes, take it seriously. And that, that's I would say a bane of a primary care doctor, is getting all the diabetics to take their diabetes seriously. Because if they do not take it seriously, bad things happen to them, but people sometimes like to ignore it and hope it goes away. And if you ignore it, it just gets worse. And therefore, you acquire more complications from it. And diabetes isn't usually nice enough just to kill you off. It usually takes you in little pieces. It's not a good disease. Exercise is good for you. Don't eat a lot of salt. It's bad for you. When you get a physical, and this is something I routinely do, particularly in people over 40, a doctor can do a lot just in a basic physical to see if your arteries are open. And one of the real basic things is just feeling pulses. Not just your pulse here, because this one's always good. But you can feel them up here in your carotids, and if they're soft and bouncy, that's kind of good. And the doctor should, or often should, listen with their stethoscope and see if it's making any turbulent noises, because if it's narrowed, it'll make turbulent noises. And you can kind of listen there. And then a real nice indicator that your arteries are open, if you can feel the nice bouncy pulses in your feet, those are the ones furthest away from the heart, generally means your arteries are pretty good. And so part of a routine exam really should be that. And if you're feeling like me, if I'm feeling around and I don't feel anything, I usually do a study to see if they're blocked. But most of the time I can feel them. So that's what, if you ask your physician that if you have circulation problems, that's how he can tell you with just an exam whether you may or may not. And of course, you have one of those TIAs, or transient ischemic attacks, see a doctor. There's a reason for that we'll get to. They can actually do something about it that may help you. All right. It's kind of a review, but when you're having a stroke, what's really going on is the blood supply to an area of your brain is blocked off, or, God forbid, you're having bleeding in your brain. I'm going to comment on the bleeding in the brain thing really quick because it's a little different. That generally gives you the worst headache you can possibly imagine, and it's really painful. Generally, and the symptoms from it are generally, if it's a large bleed, are generally very profound, like lose consciousness stuff. Little different than ischemic strokes that are usually not painful, but they're usually loss of nerve functions. And I mentioned these before, but numbness or weakness. And again, it's kind of funky, but the way the brain's wired in, if you, let's say, have a stroke on the right side of your brain that affects the area of your face and your body, the right side of your face is going to be affected, but the left side of your body is going to be affected. It's just how you're wired in. And so it's usually, if it's a face, arm, leg thing, well, it's going to be one side of the face, but the other side of the body. It's just the wiring. It can present, though, with just functions that are more the more cognitive or thought-driven functions, like talking and understanding. If a person's basically a normal, articulate human being and all of a sudden they're talking gibberish, or they're looking at you sideways when you're talking to them in a language that they normally understand, that can be a stroke. And that can be the only thing that's happening. A classic transient ischemic attack, like they taught me in med school, was when you lose vision in one eye, like a shade going down in that eye, and it just shuts off. And then if it's a transient ischemic attack, it comes back on. If it's not, it doesn't come back on. But a stroke can just be loss of vision. The severe headache thing has to do with bleeding, and I mentioned that first because they're both called strokes, but hemorrhagic strokes are really kind of different. The one that's kind of a wrench in the works is the sudden onset of dizziness or loss of balance and unsteadiness. A stroke absolutely can do that. A stroke to an area of your brain called the cerebellum that controls balance. But vertigo can do that too, and vertigo is really common, where vertigo can be caused by a virus or a little crystal floating around in your inner ear. And so, if you wake up and you sit up and the world's spinning, and that's all, and you're feeling sick in your stomach, and that's all that's going on, it's almost never a stroke. It's almost always vertigo. But if you're at real high risk, you need to be. And so, like, what's a high-risk person? It's an older person with high blood pressure who smokes, who has atrial fibrillation. They wake up and they're dizzy. It's probably just vertigo, but you got to kind of make sure it's not a stroke. That's one of those calls that technically it could be, but usually isn't, but it can be. And the reason I kind of say that is every case of vertigo and you need to call 911, probably not. We would probably overwhelm the system with vertigo. But those other things, you should probably do so. And the reason is in the last 20 years or so, it used to be, when I was first training, and I remember stroke treatment changing during my training. You'd have a stroke, they kind of say, yeah, you're having a stroke. Okay, you're having a stroke. I'm sorry. Ooh, that looks bad. And that's kind of what they did. And they just kind of watched you have it and dealt with the consequences afterwards. Well, they developed protocols for stroke where they can actually restore the blood flow to the brain and save brain tissue now, much how they do with heart attacks. They don't do bypasses and that kind of thing, but they put stents in and they use things that break up blood clots. And so the purpose behind seeking immediate medical attention is if you do get seen right away, there is a chance that the modern medicine can minimize the damage from the stroke and make it less than it would have been if you did not go. And perhaps save your life and perhaps prevent any long-term nerve problem where you would have had a bunch of long-term nerve problems. So that's why you should be aware of what a stroke acts like, and that's why you should get to a hospital as soon as you can if you're having those symptoms. And again, you can't tell a TIA from, you can't tell one that's going to be transient and go away from one that's going to come and stay. So if the nerve deficit is there and it doesn't make sense, get taken care of. So what do you do to prevent a stroke? Well, what you do to prevent a stroke is the same thing to prevent heart attacks. It's that old cardiovascular risk thing that us primary care doctors love to just drive home. And so, you know, control your blood pressure, don't smoke, exercise regularly, oh my goodness. Eat healthy, control your diabetes. Oh yeah, that stuff. All that stuff. There's maybe some things that, well, backing up. Doctors use all kinds, you know, we're big on pills. And I'm not actually all that big on pills. I'm really big on lifestyle, and then if you do the lifestyle right and then you still need pills, then okay. But the types of things that we use for, you know, high blood pressure and high cholesterol and diabetes, those medications that we use to help control those things are all things that, if they're necessary to control the conditions, are also things that help control your risk for stroke. There's a lot of folks who have high blood pressure and diabetes and high cholesterol that can make huge headway by eating healthy, by exercising, by doing all that stuff they taught you in 4th grade in health, you know. And so I really encourage that. But those medicines, if you've done that stuff, or even if you refuse to do that stuff, those medicines are necessary or can be helpful in reducing your risk of blowing a gasket. There are things that are kind of over the counter that people talk about that might help. Aspirin, little low dose aspirin, what it does is it thins your blood a little bit and helps prevent little blood clots from forming in narrowed arteries. It's a little bit of an anti-inflammatory as well, and that may contribute to how it helps. In a person at high risk for heart attack and stroke, meaning they are over 50 and have more than 2 risk factors kind of thing, like say they have high blood pressure and high cholesterol and they're over 50, the benefit of taking aspirin in terms of prevention of heart attack and stroke outweighs its risk. And its risk is if everybody took a baby aspirin every day, about 1 in 2,000 people are going to bleed out in their stomach. So it's not risk-free because it thins the lining of your stomach and also inhibits blood clotting. So we recommend, doctors in general, recommend aspirin for people at high risk for stroke and heart attacks, but we do not necessarily recommend it for people at low risk. because at that point the risks outweigh the benefits. People talk about vitamin E, which is primarily an antioxidant, as being a good thing. I think in moderate doses it is a good thing, but there were studies that were done of people using it in high doses and increasing the risk of certain cancers, which made absolutely no sense why it would do that, but it appeared to do that. Moderation's fine, 500 milligrams or whatever, that's okay. Around there somewhere, I think. But I don't really necessarily recommend it. I'm just saying if one is going to do it, don't do it in real high doses. And in a moderate dose, it's probably fine. But its benefit, the benefit is theoretical. It's actually never been proven. And the theoretical benefit is, very appealing. It's a strong antioxidant when, it's supposed to decrease inflammation and all that great stuff. And on paper, it looks great. But when it was studied in, I think it was Finland, bad things happened. And people, they were giving it to, they were taking it in smokers to see how it does to prevent cancer, a group of smokers and non-smokers, and they ended up getting more cancer when they took it. I don't know. It was a big study though, so they think the results are real. Omega-3s though, I kind of like omega-3s. I like those. That's that fish oil stuff. And that's an antioxidant. It thins your blood a little bit, so it helps prevent blood clots a little bit. It helps lower triglycerides a little bit, but overall is probably a healthy thing to do. And I think its benefit is not really in how you measure cholesterol levels, taking it or not taking it. I think it's actually probably a good thing. And people have done it for a long time, and it doesn't seem to cause any problems. And so a lot of folks do that, and I would support people doing it. I wouldn't insist that they do it. But if they did that, I'd say, that's okay, it's probably a good idea, it's probably good for you. Questions? Please.
I remember hearing that if you are an observer and you think someone is having a stroke, you're supposed to have them raise their arms above their head, repeat a sentence.
Right. There's a little.
Like
yeah, I think the mnemonic is face, actually, if I can remember right, which is face. Face is for, it's a mnemonic, but it has to do with checking for neurologic function. So if you're observing somebody and you're thinking they're having a TIA, what that little thing that you read is asking you to do is to do a quick neuro assessment of them to see if in fact they're having a problem. I didn't talk about that, and the reason I didn't talk about that is because if you are observing a loss of neurologic function, you're observing a loss of neurologic function. If you notice, and it can be speech, it can be motor, it can be visual. And so somebody's, for example, the speech one, you're talking to them, they're giving you the funny look, and then you go, can you understand me? And they don't respond. Well, they're probably having a stroke, and so you just act on it. If somebody's getting sudden weakness or numbness on one side, and they usually complain of that, because you're fully conscious usually with these smaller, non-hemorrhagic strokes. The person's fully aware of it, and if they're telling you that, then you just kind of recognize that. But what you read is kind of doing a neuro assessment. Talk for me, blink your eyes, smile, raise your arms, touch your toes, stand on one foot. Those are all, that's kind of a quick little neuro exam. But I don't think you really need to do a quick little neuro exam. You need to recognize that something funny is up, and it's a loss of function that shouldn't be there. And it's more of a kind of a general concept, because the possibilities of what short circuits is actually quite many. But typically, it's speech, facial muscles, weakness, arms, legs stuff, typically. Because there's kind of a commonplace strokes are. It's kind of the little blood clot forms that goes to the middle cerebral artery, and that's the speech center, and it also controls motor strength. And so that's kind of the common presentation. It's the speech thing or the weakness thing. Anything else? Yes?
Typically, I guess more often than not, there's going to be a loss of brain function. I guess if it goes on long enough and enough of the brain matter dies off, what percentage of time are people able to retrain the brain to get that functionality back?
Virtually everybody has some degree of remapping is an expression to use to describe that. But yes, when you've had a complete stroke and the brain tissue dies, that tissue's dead. And it does, as far as we understand it, it doesn't grow back, which is actually becoming a little bit of a, maybe it does a little bit. But I was taught, and I'll stick with, right now it doesn't grow back. But what happens is other areas of the brain can be taught to be recruited to perform those functions. And that's what stroke rehab is all about. And then percentage of recovery of function, well, it's like anything else from a medical perspective. There's a spectrum of how much damage occurred to the stroke. And the more damage that occurred, the less likely they are to restore full function. But some degree of functional restoration happens in virtually everybody, that you can get things to work that weren't working. And people can have rather profound deficits that can get near normal over a period of time of retraining that can be 2 years, 3 years. But then there's things like something called aphasia, where your speech center gets a stroke and you just can't get it back. There are times when you can't retrain that, and the person, they can understand, they know what they're trying to say, but they just can't say it. And when they do say things, it's like, it just doesn't seem to tie into what he's trying to communicate. So it's a spectrum. And mild strokes, full recovery. Severe strokes, not full recovery, but some degree of improvement, virtually everybody with rehab. People do remap and they do regain some function, usually. Yes?
Question about cholesterol. Good cholesterol versus bad.
Right.
Good cholesterol is high. Is that a problem?
No, it's great. Let me talk about cholesterol a little bit, because cholesterol is actually a really interesting topic, because you would think, in watching all the TV commercials, it's the end-all to heart disease and stroke, and it's not. It's a risk factor for heart disease and stroke, like other risk factors. And I'll go in more detail on cholesterol in a second. But risk factors for heart disease are like genetics, your age, high blood pressure, diabetes, smoking, cholesterol. Now, when I was training, which is 25 years ago, my God, it was not yet proven that cholesterol was an independent risk factor for heart disease and stroke. Now, they thought it was, but they had not yet proved it. And it took some really huge population studies to actually establish it as an independent risk factor, because already known risk factors they weigh heavy as well. So you have somebody who's old with a family history with high blood pressure, who smokes, who's diabetic. It's hard to tease the cholesterol component out of that. But it's one of many risk factors. And so when you're dealing with cholesterol, you deal with it in context of your other risk factors. If you have no risk factors whatsoever, my wife is a great example. Everybody in her family lives to be 98 and dies of pneumonia. Okay? She doesn't have high blood pressure. She doesn't have diabetes. She doesn't have, blood pressure is like 105 over 50, that kind of thing. But her cholesterol is crazy high. What do you do with that? Well, geez, I don't know. It's kind of weird. But there's guidelines, and you follow them, and she gets it treated. But that means she'll live to be 105 and die of pneumonia, I guess. I don't know. But nevertheless, cholesterol is kind of like this. There's target values, and target values depend upon your underlying health state. Let's say you do not have heart disease and you are not diabetic. The target values for cholesterol are like 200 for the total, 40 or more for the HDL, the good cholesterol, high density lipoprotein, or happy cholesterol. HDL is happy, it's good. And 130 or less for the LDL, which is the bad cholesterol, L being lame. So you have the lame cholesterol and the happy cholesterol. You want the lame stuff low, you want the happy stuff high. The higher your happy stuff is, the more protective it is against heart disease. And so 40 is good, 60 is considered protective, 190 would be phenomenal, but doesn't really happen, but 90 is fine. People run around 90 and 100. But what happens when you have a very high HDL is that your total cholesterol looks artificially elevated. So let's say you have an LDL that's a good number of 110 and you have an HDL of 100. You add those together and then you got your total of 210. There's usually another 30 floating around that's not accounted for that. So your total is 240. and you look, oh, my total's 240, that's bad. But it's not. Your HDL is like 90, 100. You're fine. And your LDL is less than 130, so you're fine. And the reason those numbers are based upon population studies, people that have numbers, it's really the HDL and the LDL, though. Total, it depends upon the HDL and LDL whether the total means anything. It's HDL and LDL. But the reason those numbers are picked, it has to do with population studies and frequency of cardiovascular events that happen with people with numbers higher than that and lower than that. And it's not, it has to be taken in context of everything else. Now the guidelines change if you have heart disease. If you have heart disease, they want less than 70. If you have diabetes, they want your LDL less than 100. And again, it's, you know, but all these guys go to these conferences, you know, and sit at tables and decide what to do with cholesterol, and they got to do something, so they make all these guidelines. But as a general rule, the lower your LDL, the better. The higher your HDL, the better. And a quick comment about the medications for cholesterol. There's a bunch of different ways to treat cholesterol, and, you know, dietary is one. You can get a 10–15% improvement in your numbers with dietary measures and exercise and such. There's something called binders, bile acid sequestrant, some stuff, niacin can help it, and statin things, and that's like Mevacor and Zocor and, you know, Crestor and all the cores out there. The ones that have the most potent effect on the cholesterol numbers and the best effect of preventing the complications of high cholesterol, which is really where it's at. You know, I can make the numbers perfect, but I haven't improved your risk. I haven't done anything. I've just made the numbers look good. The ones that do it the best are the statins. Second in line is niacin. And then the bile acid binder things are third in line. And what it means is that the statins decrease risk by 40%, the niacin about 20%, and the bile acid stuff 10 to 15, something like that. Not a lot. The statins work probably for two ways. One is to lower the cholesterol number, and it does that by blocking your liver production of it. Seems a little creepy, but that's what it does. But it also acts as an anti-inflammatory. And a big part of development of vascular disease has to do with inflammation. And the statins decrease inflammation. And so probably this 30–40% deal in reduction of risk has to do partially with the cholesterol reduction and partially with the anti-inflammatory effect, and to what degree each one matters is still to be sorted out. But in general, if I'm going to treat somebody for high cholesterol because they're at risk and their numbers are too high, I kind of like to use the statins because they work in preventing the complications the best. I guess I'll make another comment about that because it's just an interesting thing to me. Let's talk about what a 40% reduction means. Well, if you have somebody at really high risk of a heart attack and stroke, and they got like a 50–50 chance of having a heart attack and stroke in the next year, you reduce that by 40%. You've taken that 50 and you've made it 30. That's a 40% reduction. So if you had 10 guys like that, 5 of them would have had a heart attack or stroke, and now you made it so 3 of them had a heart attack and stroke. And that's what a 40% reduction does at the very high risk end. Okay. Now let's say you're low risk, and you say you have a 1 in 100 chance. Yeah, I mean real low risk in real life, 1 in 1,000. You have a 1 in 1,000 chance of having a heart attack or stroke in the next year. You reduce your risk by 40%. What has that done for you? You now have a 0.6 in 1,000 chance of having a stroke instead of a 1 in 1,000 chance of having a stroke. Now, so is that, it sounds good that it's a 40% reduction, but what has it really done for you? That's interesting. I'm not sure. So you got to kind of look at treating these things in context of your overall risk and the risk and benefits of the medication and what you're really buying with it. But yeah, you know, when people say, oh yeah, this study proved this reduces your chance by 30% and 40%. Well, it depends what your chances were to begin with, what that really means. And there's this statistical game you have to keep in mind, and I have to keep in mind when I'm recommending medications for people and, you know, making decisions with them regarding their health. Anything else?
I feel that that's
Red rice yeast is essentially Mevacor in an herbal form, which is a prescription cholesterol drug. And red rice yeast has a essentially identical chemical in it, and therefore it does reduce cholesterol. But the issue with it from a doctor's standpoint is that the product itself is unregulated, so dosing may be inconsistent. Otherwise, I have no feelings about it. Positive, it's okay. Nothing wrong with it. Another latest greatest is plant sterols. And I don't know if anybody's heard about those as a cholesterol lowering thing, as a natural way of doing that. Not a lot written about it yet, but anecdotally I've seen some pretty amazing things with plant sterols. Because people worry about the side effects of the cholesterol medicine, and what they worry about, well, they worry about a couple of things, but what you really need to worry about, what really happens is it makes you hurt. That's muscle pain, cramps, soreness, that kind of thing, and rarely gives you trouble with thinking, which the manufacturer says it doesn't do, but I've seen it do it. People worry about that. Now that's really, really, in real life, maybe a 10% thing. People have substantial problems with that. And to a large degree, you can capture another 50% of people and save them from that by just using coenzyme Q10, which is a supplement that you can use to prevent the muscle pain from, and that's an over-the-counter thing, muscle pain from cholesterol medicines. But for people who do not tolerate the statins well, I've had folks do these plant sterols, and they've had crazy high numbers to go to much less. Now, I don't know if the plant sterols are just lowering the number and not changing the risk from the cholesterol, because it hasn't been studied well enough or long enough to know what the deal is. But I've been doing that, or asking people to try that, because it seems to have minimal side effects and has had impressive changes in the values, and one would think the changes in the values would correlate with the risk, we hope. Okay. One more time.
My mother, she's 84, and about 6 months ago, I had the feeling that she might have had a stroke.
Mm-hmm.
When her doctor went to her, he thought he decided that maybe she had a mild stroke.
Mm-hmm.
So we put her in the hospital, they checked it, they ruled it out. The question is, how do we check for strokes?
Well, the most reliable imaging test for a stroke is an MRI. That's the most reliable. A test for acute bleeds that's really good is a CT scan. But an MRI is hands down the most reliable test for a stroke.
So no chemical test with an MRI?
Yeah, it's so much like a heart attack where, there's indication, there's stuff that floats around in the blood because of the muscle damage. No, strokes are, clinical exam will tell you, if they've actually had one. You can do an exam and say, yeah, they have this new neurologic deficit, and yes, that's probably a stroke. But what else can it be? Well, it can be a tumor. There's other things that cause brains not to function right. And so usually in the acute emergency room setting, they do a CT scan, because what they're really looking for is bleeds, because you treat bleeds differently than you treat an ischemic stroke. But often, the definitive test is an MRI, and MRIs are just a lot more sensitive at picking damaged brain tissue. And there's a bunch of other tests that you do if you think somebody's having, you image the carotids, you check their heart. There's all this other stuff that you do. But if you want a test that shows you where the is and a stroke, MRI. Yeah. They probably did a CT scan, I guess. Emergency room is probably what they did, which is good enough for them, because they're deciding if they have to call in a neurosurgeon or not. Because if they have a bleed, they have to call in a neurosurgeon. If they don't have a bleed, then they look at them neurologically and see, it's emergency room stuff. They're making decisions on what they have to do. And part of that decision process is, are they having a bleed or not having a bleed? And part of that decision process is what neurologic deficit or what loss of nerve function is present. And if it's very subtle, very mild, you don't put them at risk by doing these heroic things to save the brain tissue if it's very subtle and very mild. But if it's very profound, then you do. Yeah. Yeah. I don't know. Probably. I mean, I don't know the circumstance exactly. I'm just saying that that's what typically is done. And in the hospital, it depends upon the person and how they do things. But If they walked out and said she didn't have a stroke, and that's what they said, they probably did an MRI or a CT or both. But probably, I mean, an MRI is the one that you can do that and you can say they did not have a stroke. And she's 80-something? Yeah, it would be very, 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 very unusual to do an MRI on an 84-year-old and not find some evidence of some small strokes. Have them. Very unusual. Yeah, they get little ones. Little tiny ones. Yes. We good? Yeah.
One question to that. In this discussion, as well as other discussions, sometimes the phrase heart disease is used, and I've never really heard a definition of what heart disease is.
Okay.
Assumption.
Yeah, we all make assumptions. It's actually a very general term. And there's many diseases of the heart. In the context that people are usually using it, like when I talk about it here, I'm really talking about ischemic heart disease, or I'm talking about heart disease that is caused by decreased blood flow to the heart muscle, okay? Blocked arteries. But heart disease can be the valves don't work right, it can be the muscle doesn't work right, it can be the electrical system doesn't work right, it can be infected, it can have, there is a bunch of things that are heart diseases. It could be built wrong, you know, congenital heart disease. They didn't put it together right. It's got holes where it's not supposed to. It's got chambers where it's not supposed to. It doesn't have chambers where it's supposed to. You know, there's all kinds of heart disease. But in the context of this discussion, they're really when I use it in context of stroke, actually two things that matter. One is the rhythm problem, atrial fibrillation, which is sometimes caused by decreased blood flow to the heart muscle, but not always. And the other is just narrowing of the arteries, you know, ischemic heart disease like heart attack stuff. But yeah, the heart disease is a very general term. It's kind of like dermatitis, which means inflammation of your skin. But it doesn't tell you at all why it's inflamed. There's all kinds of reasons why it's inflamed. But yeah, so it is a general term, and there's lots of different things. Anything else? Yes?
So if you had a stroke years ago and it was never diagnosed, it can be traced, there's a trace of it?
Yeah.
Like 20 years ago?
Yeah. If you had a damage to the brain from loss of blood flow to the brain, that part will show up on an MRI 20, 30 years later. Depends. Sometimes yes, sometimes no. It depends. But it will show up on an MRI almost always. There was this lady I saw at UCLA when I was a resident. She was about 53. She was an executive secretary in one of the departments there. And she did computer work. And, you know, a lot of graphing stuff, imagery stuff, writing report stuff, was great at her job. And she came in because she was just feeling kind of spacey. And, you know, kind of look at her and said, yeah, you are kind of spacey. And she couldn't do certain things that people normally can do. It's like, it's just silly stuff that doctors do. But like, you ever try to draw a clock, you know, with a face and the numbers and the hands that say 12 o'clock? No way. She'd draw a circle, numbers be over there. And it just was really bizarre. And there are certain words she couldn't say right. It was just weird. So we ended up doing actually an MRI on her. And they were new then. They were all fancy. They were doing an MRI. That's cool. About 80% of her brain was gone from multiple strokes. And then when we tested her in detail, huge deficits everywhere, but she totally could compensate with her job through the computer. And she could still function. But she had multiple strokes from multiple small emboli, little blood clots going. But like her brain, there's this huge areas gone. But she was like, you know, unless you were paying attention, she was, you know, maybe a little spacey. But it was a lot of frontal stuff, which is not motor sensory. That's kind of, and you know, so, yeah, weird. You know, it's just, it's sad. You can't, I mean, you know, I graduated and moved on. I don't know exactly what they did. She ended up in the subspecialist's hands, and I'm assuming they treated the source of the emboli and tried to prevent further strokes. And then to the degree that she could be rehabilitated, they rehabilitated, but she kind of self-rehabilitated. She compensated for her deficits using other mechanisms. But again, you know, kind of a point is that she developed these deficits, but she never had any pain, she never had any headaches, she didn't, nothing. Just, oh, I can't do this. Oh well, I'll do it this way.